Our session today tackles one of the biggest paradoxes in modern health systems. Everyone agrees prevention is better than cure, but we still spend almost all our money on treatment. Stuart just told us that 9 times the amount of money is spent on people in their 90s versus their 30s. Andrew just posed us the challenge: how do we get people living healthier for longer, and how do we keep people in work? Across the NHS, about 5% of total spending goes towards prevention. And despite all of these extraordinary advances in genomics, digital health and behavioural science, the system still primarily rewards activity and not outcomes. So the question which we'll explore today is not why prevention matters, I think that's very clear, but why we still don't fund it properly, and what needs to change for prevention to become a serious investment priority. To unpack that, I'm joined by 3 world-class leaders. They've shaped this industry from very different angles. On the far side of the stage, we have Lord David Pryor, former chair of the NHS of England. David understands the system's architecture and political realities better than anyone else. On my left here, we have Professor Sir John Bell, Regius Professor of Medicine at Oxford. John has led the UK's life sciences strategy and driven some of the most significant advances in precision medicine and early diagnostics. And in the middle, we have Dame Laura Lee, founder and CEO of Maggie's. Laura's work has redefined how we think about human-centred care, community, and well-being in practice. So together, we have policy, science, and the people. The 3 levers we need to pull if prevention will ever be properly funded. So I'm going to begin with a simple question for all 3 of you. Maybe start with Dame Laura Lee. In one sentence, what do you believe is the single biggest obstacle to shifting capital and policy from treatment to prevention?
Thank you. Really interesting to be here today. One sentence, but 2 things. I think we just take too short-term approach to how we are spending and allocating and funding our money. And also, I think we have a healthcare system that's primarily delivered through the banner of the NHS that does not work well enough in partnership with private and social enterprise.
Fantastic.
Yeah, I think it's a tough question, Liz. I've thought about it a lot, and I think the fundamental problem is that in 1948, 1947, when the NHS was set up, it combined the insurance policy with the ownership of the hospital system. And the result of that is that from a cultural, financial, and sort of managerial perspective, the NHS is wedded to late-stage hospital care. And that, when you combine that within a state-owned monopoly, it makes change incredibly difficult.
Fantastic. So, John?
Well, you may not be surprised to hear that all 3 of us got the same answer, and that is the structure of healthcare delivery here and elsewhere around the world has really focused on this model, which is a 1940s, 1950s model, which has, in fairness, worked pretty well. You've seen the improvement in longevity. But the reality is it needs to pivot. And the problem with pivoting a system which has been going for 50 years is that it has a massive amount of incumbency in it. So the doctors don't want to move it. The managers don't want to move it. The NHS itself doesn't want to move to a left-shifted type organization. And that is going to be the single biggest obstacle. And that's why I don't think prevention, as we talk about it, will ever take place in the NHS.
Interesting, and that's a good segue, I think, to David. So David, as you chaired the NHS, tell us a little bit about why prevention is always politically attractive, but why it's financially neglected.
Well, I don't think prevention is politically attractive, and that's part of the problem. I mean, what is attractive to politicians is hospital waiting lists. I mean, everything hinges on getting waiting times down. So the whole political impetus is focused on the wrong thing. It's too late. And the political cycle being 3.5 years means that investing money in prevention, you never see the gains during that election period. It's ironic, this, because the NHS is actually perfectly incentivized to invest in prevention because you've got people for life. I mean, in the US, when people change jobs, they change insurance companies. It doesn't pay any insurance company to invest in prevention. But in the UK, it does. And yet we haven't been able to capture that because the whole system is captured, as John Bell was saying, by the hospital system. So all the incentives are to drive more care into hospitals. And that's a political incentive, and it's a cultural incentive driven by clinicians.
Interesting. So I pose you the question, based on that, if you were redesigning the health system from scratch, how would you think about it? And if you could give a rough number or percentage of the budget, how would you put that to prevention? Where would you spend it?
Well, I think I would still have the insurance policy. I think the benefits, the cost benefits, and the incentive benefits of a single national health insurance policy outweigh the competition benefits that you see in the US. I mean, the costs of managing claims in the US are huge, for example. We have none of that sort of infrastructure in the UK. So I think the comprehensive sort of social health insurance policy is a good thing. It's not perfect, but it's not bad. But I would decouple that from the supply of healthcare, particularly the supply of late-stage hospital healthcare. And to the question of how much of the budget I put into prevention, at the moment around 65-70% of the budget goes into secondary care. And I think you said earlier on that 5% goes to prevention. I'm guessing that if I had to take a guess, I would reduce the secondary care budget from, say, 65% down to more like 45%, and bring prevention up from, say, 5% to 20%. It will be that kind of order of magnitude, I think.
Fantastic. And obviously, lots of your conversations historically were confidential, but were these topics ever discussed, and were these shifts ever talked about in your time?
Well, the shifts are talked about in policy terms. I mean, every 10-year plan for the last 20 years, we've talked about shifting care outside hospital. But in reality, no. Well, one of the reasons has been that, and John Bell will talk about this later on in his bit, is that the Treasury have been sceptical about investing in public health because they know that behaviour change does not work. And actually, if you're going to drive things historically in public health, you've had to take sugar out of food and salt out of food, and this is all very unpopular with various interest groups and smoking as well. But what has happened in the last 5 years is that technology has changed massively around diagnostics and preventative therapeutics. I mean, the anti-obesity drugs being classic. So now we've got some real weapons in the armory, which which JB will talk about in a minute, I'm sure. So public health has suddenly become, from a financial perspective, much more easy to quantify and to deliver. And the work that's been done on our future health, which is showing, that if you intervene early, you can have huge impacts. I mean, I was looking at some of Andrew's figures. It's easy to say from his figures, well, we should focus on people who are 50 plus or 60 plus and focus on them. But actually, to get people who are 50 and 60 plus to stay healthy, you need to focus on them when they're more like 30 and 40 by predicting. By predicting, is that working? Can you hear me at the back? Yeah, but by taking a much more predictive and preventative approach.
So you mentioned investment, you mentioned shifting frontiers. Great time to bring in Sir John here. So in terms of your perspective, what are the most investable frontiers at the moment, as you see, that could be linked to prevention?
Yeah, so as David's pointed out, the landscape of this has changed completely. If you'd had this conversation 10 years ago, you would have had a lot of public health doctors saying, well, we can solve this problem if everybody ate more broccoli and bought a pair of running shoes. But the reality is some people do eat more broccoli, which is good. I'm not saying that's not helpful, but it's not the way we're going to solve this problem. But what's happened is there's been massive innovation in the space, which could, if used properly, really propel this prevention agenda in an impressive way. And in no particular order, the opportunity now to use AI to identify, because you can't, one of the problems with public health is if you try and do it for the whole population and basically shift the whole bell curve a bit to the right or to the left, it's actually pretty clumsy for a lot of conditions. It works for some, but not for others. Clean water works well, clean air works well, but it doesn't work so well for individual liabilities. But now we can identify in a pre-symptomatic phase where people don't have any problems. You can say, you might have a problem with prostate cancer, or you might have a problem with cardiovascular disease. Somebody else might have a problem with dementia. But if you can identify that with, and let's be clear, these are not tight confidence intervals, but they define risk in populations so that you can actually lean into the populations with particularly high risk and intervene in those people very early. So the diagnostic things has been changed by access to large amounts of data. This also includes genomics and proteomics, but also just healthcare records. And then the second piece is that we now have therapies. And these are therapies which are pretty safe. And actually, it would be nice to pretend we invented this idea in the last 5 years, but we didn't. This actually occurred in the 1970s when people discovered statins, they discovered antihypertensives. And those have had an impact on cardiovascular disease. Cardiovascular mortality has fallen in this country by 67% in 30 years. 67%. So 6 out of the 10 people who would have died are not dying, at least when they would have previously died. I mean, it's a massive impact, and it drives a lot of the numbers that we saw earlier. That in its own, and that has been almost entirely, a little bit of jogging shoes and broccoli there. I don't want to give them and take away all the credit. But most of it's been, everybody swallows a statin. We're all managing our blood pressure. Well, we're not all, but that's what's really made a difference. If you layer on top of that some of the new innovations, small interfering RNA, and David and I were closely involved in the attempted introduction of inclisiran, which was the first siRNA to lower blood pressure by inhibiting PCSK9. That failed for the reasons I described in my initial comments. It failed because the incumbents, in brackets, the GPs, didn't want to use it. But there was a drug that you could give an injection, and a year later, your cholesterol would be fine. So it's basically a vaccine against cardiovascular disease. So the siRNA is going to be powerful. But then there's also a variety of other tools which are just evolving, which looks like if we prevent things early using those therapies, we can actually stop the ongoing set of problems. And then the final piece of this is, ideally you want to get to people when they're in the midst of this sort of metabolic miasma, which creates all these diseases, high blood pressure, high cholesterol, high blood sugar, obesity. But the diseases actually start very, very early, before you're at all symptomatic. So early detection of the disease, as well as prevention of the disease, is all part of this formula. And that's perhaps most evident in the cancer space, because although we can do a lot to prevent cancer, the best thing we can do to cancer is diagnose it at stage 1 or stage 2, because then it's a completely curable disease. So these are all the things that the innovation agenda has brought to the table. And I think they're all accessible.
And we've seen a huge amount of capital in the last 2 years flowing into things like GLP-1s,
Yeah.
which are primarily viewed as a treatment.
Yeah.
Could you share your perspective on, will that ever be regarded as a preventative therapy versus just treating an obese issue?
Yeah, so this again gets to the inertia of an existing system which is focused on end-stage disease, and that is most of those drugs are really being sold predominantly as a way of people losing weight, and they're very good at people losing weight. About half the audience will be on them, I suspect, so that's all good. You're all feeling happy. Certainly half the cabinet are on them, I can tell you that for sure. But the reality is that the data that Novo's produced on its preventative abilities to stop cardiovascular disease, but also heart failure, renal failure, joint disease, a whole set of things which we treat as aging diseases. These are really powerful tools for that. And I think we're going to get better at learning how to use them so that people can stay on them for very long periods of time. So But the real question is, will we be able to attract capital that's focused on these being used as a population health tool, not an individual tool for people who've got a bit overweight? And that, I think, when you run the numbers, is a really interesting commercial opportunity. Mm-hmm. Whether the pharmaceutical industry gets that or not, I'm not sure. So
let's build on that, because I've observed that there's fantastic science in the UK, and the US also has fantastic science, but the US are able to pick and commercialize and attract capital in to really take it to the next level. And what they typically do in the UK is they'll take it to America. That's what I've seen. So from your perspective, what's missing from that UK innovation ecosystem to really make it sustainable?
Yeah, so I mean, this is the central question. It's something that David and I spend half our lives trying to think about. But can I just use the Metsera example as an example of what doesn't work and what could work? So Steve Bloom is a terrific endocrinologist, has been based at the Hammersmith Hospital for his whole career. Now he's sort of semi-retired. He was actually retired, to be honest, but he was there when I was training as a doctor. I mean, a very impressive guy. And he really broke open this whole field of short peptides produced usually mostly from the small intestine that actually have these massive metabolic effects, of which GLP-1 is one, but there are about 50. And he had done really fundamental work in this space over a 40-year time frame. And he'd actually even spun out a little company, as we tend to do, but that company basically had a big library and no money, so it was going nowhere. Enter Clive Meanwell and our friends from the Population Health Partners. Clive is the person who developed inclisiran. He's a hugely experienced drug discovery, drug development guy, was at Roche, ran regulation at Roche for many years. And he built this team of people who said, we're going to make drugs. And so they found Steve, they took his assets, and in less than 3 years, they turned a library that was worth very little into Metsera, the product that was sold last weekend, for $10 billion to Pfizer after a massive auction with Novo. So you can create value in this space. That was UK IP, but it was American know-how. And now, having said that, guess what? Clive is British, half his team is British, but they find that doing this in America is just a lot easier. And one of the reasons for that is access to capital is completely different. And I think, it's really interesting about this discussion, and Andrew's talk about the state pension age is actually really stimulated me to think, one of the reasons that we're struggling with the state pension and when you pay it and all the rest of it is because we haven't managed our pension system at all well. And if you go look at how the Canadians have done this, the Canadians have got massive pension assets that grow at 10% a year. Most of our pension assets are either pay-as-you-go from Treasury, which is a terrible way to run a bloody pension system, or it's sitting in gilts. I mean, do you want your pensions in gilts, guys? That's earning like 1.5% a year. So the whole thing is a complete mess. And now I'm not going to try and fix the pension. I've tried that, actually. Didn't work. But somebody needs to get a grip, because these things are all tied up together. Access to capital means we've got to invest the capital that we do have in a better way to generate better returns, make the pensions better, take that load off government, and be able to generate the value in the public markets. So sorry, it's a rather long-winded answer.
So we talked about system, we talked about structure, and money does enable a lot of this to happen as well. So that's fascinating. But if we're having a healthcare conversation, we have to talk about people. So let me bring Laura in here. So Laura, tell us a little bit about your Maggie's journey, and I'll pose a question to you, which is, do we underestimate the role in current times of place, community, and belonging in the context of preventative medicine?
So I'm here on the ground, and John is going to, and David has been sorting out our futures. But in my world at Maggie's, which is about offering support to people with cancer and their family and friends, I think one of the things that has been a complete failure of our cancer care and also other aspects of healthcare is that we put people through this, can be sometimes, even if you're waiting too long or too late being diagnosed, through a a clinical factory of treatment, and we put people out at the end of it. What we haven't done is focused on the opportunities of, yes, prevention is important, but also rehabilitation. And if you link rehabilitation in with the prevention story, you can actually help people get back to productive lives in a far greater and faster form, rather than leaving people to flounder to all of the kind of life adjustments that the medical interventions have left them with. And that's where the kind of community and community-based care that isn't the GP system, it's something else, is needed. And yes, our new health secretary talked about neighbourhood health, which is a very important and good signal. But we need to create, I believe, places that can help people take active participation in their own prevention, but also in their own recovery. And I think we need to get back to the treasury of helping them understand that both of those components are really important.
Fantastic. And it's very clear from all the case studies that I've seen, and the work that you performed at Maggie's, that it's really redefined what a supportive care environment is. Can you take us through some examples or tangible lessons learned of what we could do in terms of, you mentioned obviously Treasury there, but other changes that could be made?
Yeah, we have this sort of strange commissioning structure where we refer people to something and they then have to wait. If you think about our mental health crisis, if you get a referral and you're not immediately thought to be suicidal, you might wait 18 months before you actually start to get help. And then that help is a prescription of 6 online sessions with a counsellor. So the kind of structure of how we make people wait, we allow the crisis to build, and then actually the interventions don't work. And at Maggie's, I think by helping people right at the point of diagnosis whilst waiting for treatment. And in some cases, in Oxford, if you've got curative prostate cancer at the moment, you're waiting 6 months for your radiotherapy. It's actually helping people think about what can they also do to help themselves manage the risks of waiting. And so it is about, I believe, about creating environments. Maggie's, we have amazing and beautiful buildings, but I also think that buildings can help the professionals who are working within them actually be more productive. And actually they can help signal to the individuals who are coming in that actually they need to participate in helping themselves, rather than a system of the NHS which is about having things done to you.
I think that's fascinating, because we've all touched on the broccoli example at the beginning, and you've touched there, to really make a fundamental shift, people need to start to own their own healthcare journey, because governments can only enable and educate, but people actually have to take ownership, which I think is important. Following on from that, can you touch on any barriers that you see to scaling your model, or taking a Maggie's-like structure to other care domains?
Yeah, you may have a different perspective on the NHS, but I don't think the NHS is great about, it wants to sort of still own and do everything itself. And rather than partnering with people who are more specialists and experts. And for example, in the new cancer plan, NHS England goes out to Denmark to look at how they've improved cancer cares. And what do they discover? That there is a cancer support network that have developed in the last 10 years across all of Denmark, based on the model of Maggie's. Has NHS England ever visited a Maggie's or thought about what it could learn from its own country? But also the Danish government has invested in the Danish Cancer Society to provide some of that work, only 3%, but 3% could be a game changer to something like us. So it's this inward-looking organisation, and then when it looks out, it somehow doesn't then look out and then think about actually how can we restructure and reorganise and re-partner with some brilliant colleagues who exist in this country.
Can I just add to that? I completely agree with that. The trouble with the NHS, it sits on a moral high ground and regards everybody else in the healthcare service as somehow morally inferior. And incredibly frustrating because it made it so difficult to work with partners in the private sector or the voluntary sector. And it's even when we're delivering terrible care, often, we still sit on this moral high ground. And I don't know what we can do to shift it. I mean, interestingly now, during the height of the pandemic, and I might add the pandemic was solved by people who developed vaccines and diagnostics more than delivered care, as it happened. But at the height of the pandemic, public satisfaction in the NHS hit 72%. Today it is 21%. So we have got a chance, I think, now of changing it. If we had a strong government, and I think actually for someone who's a conservative sort of type of person, I'd hope that this government might do something. But they talk about serious reform. There is no serious reform going on in the NHS. I mean, they are shifting deck chairs at the moment. There's no serious reform going on. And until there is, we're not going to solve this problem.
Perfect segue to my final question. Question for each of you, actually, it's the same question. It's the lottery question. If you were allocated £1 billion and you had to spend that on prevention, where would you deploy it first?
I think in the short term, frankly, I would extend the uptake of GLP-1s across the population. I mean, that in the short term is what I'd do. In the longer term, I'd like to move to more outcome-based care and all the rest of it. But in the short term, I'd make available GLP-1s to all those people with a BMI of probably over 30, something like that.
Oh, I'm not sure I'm qualified to answer this question, but there has to be something about that younger lives. If we can start younger, I mean, I know you said the telescope was quite well extended there, but we know it's the health and lifestyles that if we can change that in our young population, that will see change coming later on.
Yeah, so one of the interesting things that's come out of our Future Health, which is this large cohort where we start at the age of 18 and go to 110, and people have been very willing to participate in this and give us their access to their healthcare data, but also their biological data. If you look at that whole population, so we're talking about people from the age of 18 up, 52% of the UK population have a cholesterol that should have been treated because it's too high. That's half the adult population. And by adults, I don't mean people over 60, I mean everybody. 25% have uncontrolled blood pressure. And 30% are obese, using a criteria BMI more than 30. So those are all soluble problems. You can deal with all those problems with the tools we've got in the toolbox, and they're just not being dealt with. The NHS isn't dealing with it. The GPs don't want to deal with it. It's just sitting there, and it's this cause of the massive disability and ill health from multiple chronic diseases in people over the age of 60. So if I had $1 billion, one of the things I think we need to think about is how do you take people out of this formula in terms of getting these things to individuals in the population? Because one of the things, I was at a great dinner that David hosted 2 weeks ago where Tom Cabassi, who runs strategy for the NHS, was there. And he did point out that there's been this massive growth in healthcare people and professionals associated with almost no change in productivity. And that's one of the really big challenges that we've got in our healthcare system. So you need to replace those people with digital channels to deliver the kind of interventions we need to young, fit people who need them because we predicted they're going to be at risk of disease. So if you could create a system which was a digital system that did that, you could actually deliver remarkable improvements in those metrics that I gave you at the beginning that we got from our Future Health. That would have such an impact on all aspects of society. Keep people in work, Andrew, after the age of 55, but people would have longer and happier lives. It would take the pressure off. It would be a fantastic demand management tool for hospitals and late-stage care because you would not have all that disease. So you probably couldn't do it for $1 billion, but if you gave me 2, I suspect I could get it.
This is the classic American versus the British answer. Fantastic. I think we've got 5 minutes for some audience Q&A. Got a question at the back.
I'll just shout. So, can you hear me okay?
Yep.
Yeah. My name's Paul budgets, etc., we're having to kind of think about which services to decommission. We found that if we just call it treatment instead of prevention, it doesn't get, it's less likely to get cut. Basically, people actually find that just calling it treatment helps. And so my question is, I was mulling this over, wondering if that's kind of, fear of loss is twice that fear of gain. Is there something about actually the way that we're calling the narrative that was used that isn't actually helping as well? And maybe there's obviously some technical changes, but maybe there's some. Would you have any recommendations for how we maybe talk about this in a slightly different way?
We'd like to.
Well, I mean, the NHS budget is £200 billion. That's quite a lot of money. I mean, the money spent on therapeutics has dropped from around 14% to 9%, I think, or 8% of that. The money spent on capital has been switched largely from capital to revenue. I mean, the current system is running out of money and running out of road. And you go to some of our hospitals. I mean, you go to the QE at King's Lynn, for example, or James Paget in Great Yarmouth. I mean, these hospitals are falling down. There are buckets in the corridors picking up the water. There's MRI machines that haven't had their routine maintenance and stuff. I mean, the current system is falling down. I mean, if we don't replace it, if we don't get this degree of urgency, and maybe the argument that Andrew was making here, the economic argument, the return to work argument for people over the age of 50, 55, is the way to get the Treasurer's attention, because that is how we're going to get economic growth. At the moment, the NHS, the system we have, is contributing not just to lower productivity in the country, but to lower productivity and to lower economic growth. So we are running out of options. I mean, just changing the name from prevention to treatment isn't going to help, I don't think, to be honest with you. I mean, what worries me now is they're going to bring in a new financial regime for next year, which is going to be based on activity, wholly on activity, or largely on activity, which means that hospitals are going to be incentivized to do more work, which means that more money will flow into hospitals and away from mental health, for example, and from prevention. So in a way, everything we're doing is reinforcing the maintenance of the legacy hospital treatment service that we've got.
Is it time for a royal commission on the NHS to take this out of politics? We get to remove the party politics from it and the short-termist thinking that comes from election cycles. And apart from the panel here, who would you put on it?
The short answer is, I think, no, because it kicks it down the road yet again. We had the One List Commission, if you remember, which Gordon Brown set up in 2003 or 4. I mean, you can't take politics out of it, I'm afraid. However much you think you can, it is always going to be weaponized by one party against the other. So, I mean, in a perfect world, you'd have a Royal Commission of the great and the good, and they come up with the answers. And I think we all know, roughly speaking, what those answers are. But I'm afraid, I don't think it's real life.
So there is no answer?
It's like the economy as a whole. I think we've got to have a complete car crash before we sort these problems out.
But we're getting pretty close to the car crash, let me tell you. So everybody get their seatbelts on, because it's going to be problematic, for sure.
We've got time for one more, I think. Yes, please.
Hi, yeah, I'm Ian Philp. I was Tony Blair's National Clinical Director for Older People's Health here, and I just wonder if we're missing a trick about the prevention opportunity in Andrew's 4th stage of life. Because in the 75-plus population, there's a huge amount of existing problems that are not being addressed, and unlike the sort of several years to get your ROI from dealing with problems like pain, loneliness, financial difficulties, you get a 1-year return on the ROI. So a question for the panel is, what would you do to incentivize the NHS to do more preventive work in the older population?
Well, there's quite, as you know, there is quite a bit of momentum around secondary prevention. So primary prevention almost doesn't exist. Secondary, I think the medical profession sort of gets that. So when you've had your heart attack, they say, oh, maybe we should think about preventing the second or the third heart attack. And I won't say they're good at it, but they're better at that than saying to a young, fit 45-year-old with a cholesterol of 9, I think I need to put you on inclisiran. And I think it's really important that the emphasis on prevention that we've all talked about, which I think is really terribly important, doesn't mean that we denude late-stage care so it doesn't exist. No, I don't think anybody's saying that. And that's why I think we need these additional sources of capital to make it work. We either need Treasury to realize that this is going to give us, Andrew, 4% of GDP or whatever your number was. And we have to, I think, also get the population at large to understand if they want wellness throughout their life, they may need to pony up for some of that themselves, because there is a private sector play in the prevention space, which actually, as you know, is in other jurisdictions is taking off. And I think that may well be the way that you manage this in people who are younger and fitter. So primary and secondary prevention are both important.
And I would say in the 75-year-olds, which is primarily where cancer and the folks that are going through the kind of cancer system, they're just lost and forgotten about. They're not the young, striving person with cancer that the system is focused on. And they're, as a result, are experiencing worse outcomes by that neglect, mental health, isolation, and loss of access to treatments that could help them actually have a better quality of life and be more productive too.
Just on your point, Jerry, I mean, consumer healthcare is clearly moving apace, particularly in the US, but it will drive greater inequality. There's no question about that. If you can afford the GLP-1s, you'll buy them now, or indeed, or other drugs as they come on the market. So I think, we have to have our eyes wide open on this, that already, as we saw from Andrew's figures, inequality means you have 10 years less life and 15 years less healthy life. That is going to get greater as consumer healthcare replaces state-provided healthcare.
Yeah, and if I can just come in on that as a final comment, it makes me really sad, but no one is driving the destruction of universal healthcare more than the NHS. So if you look at the way they've handled the distribution of GLP-1s, they've said, over you go to Harley Street, you can buy your GLP-1s, it's all fine. But if you're a poor person up in Sunderland who is obese and comes from a poor socioeconomic background, you have no chance of getting a GLP-1. Now, that is going to drive the inequalities of health like nothing we've ever seen before. And the same applies to the therapeutics numbers. The fact that we're not making drugs available for people in the healthcare system, we're at about 40% less than the rest of the Western world. Guess who's not going to get those drugs? It's not going to be me. I'll tell you, I'm going to get the drugs. So is David. So is Laura. We're all going to get the drugs. It's the poor people who are not going to get the drugs. So I think we're seeing the beginnings of what will be a dramatic acceleration in the inequalities of health over the next 10 years.
And the poor people will not get the diagnostics.
And they won't get the diagnostics. I can tell you, this is a road crash, and it makes the whole concept of the NHS look pretty silly, actually, because it's being driven by the health system itself, which is just, you couldn't make it up, actually. It is really outrageous. So, and if anybody wants, because nobody's mentioned it, but if anybody wants a good read, you should read Charlie Mayfield's report on the impact of ill health on the working population. So it turns out that when you add up the number of people who are out of the workforce, this is to Andrew's point, because of ill health, it's costing the country £85 billion a year. I mean, it is eye-watering amounts of money. I can tell you, you could set up an unbelievable prevention system. You give me $85 billion, I can tell you, I can fix a lot of problems. But anyway, there you are. I think it's just a really big problem, this.
Before we wrap up, Andrew, you've been referenced quite a few times. Anything you'd like to say, or any questions finally for the panel?
Loads of things to say, but I always just think of Herb Stein, who was the economic advisor to Nixon, who said if something's unsustainable, it comes to an end. And I think we were talking about an unsustainable health system, so the question is, we need to brace ourselves to replace it, because it will come to an end soon.
Yeah.
on that very happy note, a big thank you to the fantastic panel. Please put your hands together.